We have a pretty lengthy agenda this evening, and Janae and I are going to kind of tag team the presentation here, but we had, like last time, actually more so than last time, I think we've left plenty of time for questions, so I think that will be helpful. Claire, if you want to go to the next slide. I am really happy to see everyone here. I'm gonna go ahead and state this, but I'm gonna prompt at the end. I really want to get some feedback from folks who have joined, like Aaron, you've joined twice in a row, which is amazing. I want to get some feedback on how we might be able to better engage folks to attend, because I think that some of the things we're going through here are really important, and there might be multiple ways we can communicate out, but I want to make sure we are spreading this type of message far and wide, and then of course always given a forum to take questions. So I'm going to dive into some agency priorities tonight, because one of the ways that I want to use this forum is to not just talk about things that are happening within Child Protective Services or the Family Wellbeing Division overall, but to talk about agency efforts, because the interplay in Health and Human Services is significant. So we're going to run through those. We're going to talk about some Child Protective Service specific initiatives. Janae will cover that. And then I'm going to talk about QRTP, Safety and Security Enhancements, which is an initiative that has been in the works for quite some time, but is rolling out now. And then hopefully we'll have some dialogue. Okay. There we go. So 2 items that I really want to focus our attention on this evening. So we spent a significant amount of time last session talking about how we diversify our out-of-home placement array and really focus on serving the needs of high acuity youth. And in that, we were able to secure a new Medicaid funding stream that allows us to have an enhanced rate for PMICs. And this is many, many years in the making, honestly, really kind of culminating in working with our providers in the state to think about capacity, to think about what's missing in our placement array, how we could bring some of the youth who are in out-of-state placements back home, which has always been part of our goal. And so we are tremendously excited to really be now in the actual build stage of rolling this out. The Medicaid team is working very closely with our behavioral health team, with Janae's team and family well-being, and with our providers to make sure that we are hitting the mark here. You'll see us go through a competitive process to secure these new providers. But the way we're thinking about it is a little different than you see kind of competitive from our agency in most spaces. We're thinking about it more in open panel arrangements. So if you meet qualifications at this certain level and you check all of those boxes, we would keep the panel open and ask providers to come in with the state's ability to cap capacity once we meet that particular threshold that we're looking for in terms of bed capacity, obviously working with JCS hand in hand on what their needs are as well. And PMICs serve more kids than just Medicaid eligible children, right? So it's really thinking about, from a broad-based statewide perspective, what do youth in Iowa need? So this opportunity is really significant, and we're going to continue to work on this as Janae and I are in the not even so early, kind of in well underway in terms of thinking about what next session will bring and what priorities we will bring forward. Next session will be heavily focused on our Medicaid waiver redesign. The Medicaid waiver redesign project is entitled Home. It's Hope and Opportunities in Many Environments. It's really structured on taking our 7 Medicaid waivers and transforming them into 2. So simplifying that process, making sure that Iowans who are awaiting that service array understand where they are if they're looking for a service that has a wait list, and that they're able to check that in more real time. And then really simplifying the ability to assess, to be deemed eligible, and most importantly, going from a diagnosis-based waiver system to a needs-based waiver system. That's actually the most important part of this waiver redesign. And it's right alongside all of the work we've been doing around serving high acuity youth. You know, what we have had in Iowa is a bit of a one size fits all, but based off of diagnosis. You can even see that for some of our NAC beds, for example. And humans come in a lot of gray forms. may not meet a specific diagnosis, but have a level of need that is absolutely analogous to what that diagnosis typically presents. And so our waiver redesign is really centered around that. It's centered around making sure that we are working in a person-centered approach in our array of services, building an a la carte menu instead of something that is more buffet style, kind of all in. You're all in and you're getting that service array whether you need it or not. In that process, we are right in the middle of the cost calculation piece, really gearing up again for budget conversations that for us begin in the latter part of the summer, and making sure that we are briefing both the governor, her staff, as well as ultimately the legislature on what investments might need to be made to support individuals with disabilities, many of whom are children involved in child welfare. Meanwhile, we continue to work with the plaintiffs in our Medicaid class action lawsuit. And that's a space just to kind of orient you to the conversations if you have not been following this at all. I was served about a year and a half ago at this point, with a lawsuit that is aimed at Medicaid eligible children who have serious emotional disturbance. And so it's not specifically aimed to child welfare, youth involved in child welfare, but many of the youth involved in child welfare are part of that class. So it is a broader conversation, but we have been working with the plaintiffs who filed the lawsuit against us very closely for some time. We chose to enter a mediation process instead of going to court because ultimately myself and all of the leadership on our team have spent a lot of years recognizing the spaces where we need to shore up gaps and intending to really to step forward and fill those gaps to meet the needs of all Iowans, especially Iowans with disabilities. And so that work also is underway, and it will come accompanying this work around high acuity youth and accompanying this work around waiver redesign, so that at the end of it, we have an actual system with the right sets of placements, smaller, more specialized settings. And we believe that to be the space that our state needs to head. Meanwhile, and Janae will probably carve out some time just to think about this and talk about this and maybe in the next town hall, but we are also, as part of this work, really thinking about how to end the need for group care as we know it, and thinking about the spaces that need to be specialized within the array of services that are specific for children, youth involved in child welfare. So that's to orient you to that broader work, to think about the way that Janae and I are both in our respective roles really championing this conversation at a national level. Both of us have been invited to participate in really specific engagement. You can still go, well, I'm about to go to behavioral health, that's fine. But the really specific engagement at the federal level to make sure that we are honing in on what's right for Iowa always, but really learning from what other states are thinking about as well. And just some perspective for those on the call, our team, including our CPS director, Lori Frick and Kristen Konchowski, attended the Rural Child Welfare Convening a couple of weeks ago. So 26 or 27 states in that forum, a large number of states. And we were the only state in that forum not sleeping youth in offices, Airbnbs and rented hotel rooms, the only state. So the problem around serving high acuity youth has only grown nationwide. And last week I went to DC. I'm chair of APHSA's Leadership Council, and we met with the leadership from ACF, including Rebecca Jones-Gaston, around meeting the needs of high acuity youth, what we expect to see from HHS as a broader department structure, because many of these tools, in fact, most of them, are not within ACF's ability. They are an HHS response that is needed, specifically SAMHSA, specifically CMS, or maybe most primarily CMS. So we continue to sound that alarm about how grave the circumstances are for states, and to make sure that we are keeping pace with the needs of youth and supporting our providers in that respective capacity. Sitting alongside that work, but really, again, being implemented in tandem with this other redesign that is really kind of very specific to Medicaid and child welfare, is our work around behavioral health. And this slide really lays that out. So we have done a gap assessment. It's what it's what became our home project and waiver redesign. And alongside that, we did a really significant amount of work around the gaps in behavioral health services, and really focusing in on the linkages between substance use networks, which is our Iowa Provider Network, IPN, and the MHTS regions, which are fragmented and fractured, kind of sitting outside of a number of other systems. What Janae and I see on a regular basis, as both of us take it upon ourselves to dive deep into cases so that we are understanding the needs of the youth we serve and who are in our care and custody, but also so we are able to translate the needs of a specific individual into system changes, which it is paramount that we do. And what we saw is that often we would find individuals in kind of one of two spaces at opposite ends of this kind of spectrum. Either they've fallen into a complete gap, despite having somewhere between, at bare minimum 3 case managers, but at max maybe 5 or 6 case managers. But they've landed in an ER, not receiving the services they need, or they just don't know how to navigate that system at all because it is disconnected, and people tripping over themselves to try to navigate the space of where you go to receive a service in the right time. Child welfare is the recipient of that broken system, right? It's not the sole recipient. Our judicial system is also there, and corrections is there. But this space is a safety net place of last resort. If we fail upstream, families and youth come into our child welfare system. And so this linkage and kind of looking at it through the lens of early primary prevention and early intervention is what spurred us to make a recommendation to the governor to take a fractured system, substance use, mental health, and other addictive disorders work, and to move that into a new system that allows the state to see very clear minimum standards, equalizes and ensures equitable access across the entirety of the state, and really better ensures that what used to be known as regions that will now be known as districts are really meeting the needs of the area that they kind of represent, but removing some of those artificial barriers that exist in today's structure. Today, if you cross an MHDS region line into another region, if the provider is sitting on the overside of that line, but you may not understand the map, the region has the ability to not help you, and furthermore, to not pay for your services. And that is a problem. So we came to the governor championed this work and introduced a bill which had phenomenal bipartisan support, was passed and signed into law, up with Emily Bloom at Foundation 2 in Cedar Rapids. And we are now deep in the work of implementation to build a new behavioral health system. What you see on this slide is exactly what we expect to achieve over the course of come July 1 next year. And you will be seeing a lot of work from us around this. And I want each of you to understand that that work is paramount to ensuring that access to services in all areas of the state are available. It is a huge build, and we recognize the gaps, especially in spaces like mobile crisis and crisis stabilization. So more to come on this, and absolutely want to entertain questions at the end of this presentation if you have them on home, on this behavioral health work, or any of our work around centering to serve families. We do have a webpage, and so Claire has lovingly put the QR code so that you can scan it and find where we put all of this information on our webpage. Or if you want to be part of the dialogue with us around implementation, and we're very hopeful that many of you will want to. We have a number of different town halls. We kicked one off last week that was virtual. We have one on July 1st at River Place in Des Moines, 1 to 3, one on July 8th that is a virtual 12 to 1, and one on July 18th up in Sioux City at Rosecrans Jackson from 12 to 2. So we look forward to taking feedback and really look forward to our continued robust dialogue to really strengthen our network of behavioral health services in the state. Okay. This is a big one. We're transitioning here. So we have been giving a lot of thought as a byproduct of alignment, a natural space. We're 11 months in to our new organization, nearly 12. We'll have a birthday here come July 1, but nearly 12 months into our new organization. And in doing that, over the course of the last year, we have been detangling the income maintenance eligibility structure from child welfare, building out adult protective services in a new area of the agency. We redid our budget with the partnership, with obvious support of DOM and iGov and the legislature this last year, all to be better reflective of what it takes to do this work across all of health and human services. And in looking at that work and really kind of uncoupling or maybe even diving deeper than the agency has before, we've come across a number of different areas where we see room for improvement, and this is one of them. So in the Appropriations Act that will go into effect July 1, and PS, this has been in place for quite some time, we have a specific appropriation for court-ordered services. And over the course of the year before this deep budgetary work, Janae and her team had been diving really deep into better understanding how we're spending money. Some of that came in the forms of court orders that we as an agency worked with the AG's office to appeal because we felt like they weren't within the spirit of what court-ordered services should be or what our dollars should be paying for. But an overwhelming and resounding analysis, I mean, it was clear as day, was that we have overspent this appropriation collectively by significant amounts. And that is not something that the agency has ever really honed in on historically. It is something we have just now been able to get our arms around with our budget team, given, again, the maturity of the organization. And it is absolutely something we have an obligation to work with the legislature on to make sure that we stay within their appropriated amounts. We very much recognize that underneath court-ordered services are valuable and non-negotiable, like they services that have to exist in child welfare. And so we are cautious in that we understand that something has to change here, but we also have to rein in the way that we're spending these dollars. And to be able to do that, we need to be tracking how court-ordered services are being spent, what they're being spent on, and by area, I mean, down to the point of by judge, because we need to understand how to ask collectively for the right amount of money for the right sets of things in the system. I mean, at its core, that's what we're trying to do. The legislature has entrusted us with this amount of dollars to do this work. It's not working. It clearly, it is not historically in the last years since I've been here, has not cost that amount of money. But also we have questions about some of the types of services that are being ordered and paid for out of this particular fund. So clear that it's a not to exceed amount, but thoughtful about the way that we need to move forward. And so we've pulled together here some of the language that comes from the Appropriations Act so you can just dive deep and see it. This is not our interpretation. It's very, very clear. And pulled from code, of course, what code directs a judge to do, a court to do, in terms of what buckets of money they have available to order other services. So before we wrap here, what you're going to see from us moving forward is tracking around expenditures. We want to shine daylight onto this process within our agency and then work collectively to come up with a solution. But first and foremost, it's really making sure that legislators have an understanding of the spend that's happening here. So I feel certain that with shining that daylight, we'll be able to come up with something for next session that allows us to take an appropriate step forward to both kind of rein in some spaces, but really normalize the appropriate amount of dollars for the appropriate sets of services in a way that meets the legislature's expectations around spend. And so more to come there. And I think we should put it as a standing item to walk through that dashboard, Janae, on this forum and in a few other spaces so that there is real clear daylight on this issue as we move forward. Now, Janae is going to walk you through CPS priorities.
Thank you. I would also add, Director Garcia, I think that it will be really important for us to hear from the judges what is the best pathway for us to keep them aware of that appropriation, the expenditures, and the remaining balance. And we will adjust our communication as we hear more what works on their end. So in terms of CPS priorities, the first place I wanted to start is to give an update on our case permanency plan pilot. A work group was initiated in April 2022, and we spent an extensive amount of time reviewing state and federal requirements. We pulled examples of permanency plans from other states, and we pulled together this work group. We used lean principles in order to develop the new case permanency plan. Once we came up with our design, we decided we wanted to pilot it. And we are extremely appreciative that there were around 5 judges who agreed to have these revised versions of the plan used in their courtroom. And after experiencing the updated plan, we then interviewed them to see what did they like. They gave additional feedback on the things they did not like. And what they identified is there were improvements, but it was still not quite as user-friendly as they had hoped for. They really wanted to see a summary, a consolidated information and update on what was going on with the case at the beginning of the case plan. They really wanted to see the goals, the treatment expectations for the family clearly mapped out. They wanted to know who was responsible for what in what timeframes, who was helping them. And so they could really benchmark the success of the family. And a lot of those desires that we heard from the judges dovetail very nicely with our system movement towards implementing motivational interviewing. Motivational interviewing is very much predicated on understanding and working with individuals' goals, making sure they were motivated, making sure they understand what they're working on. And so that is going to, the revised permanency plan is going to really complement that broader system implementation around motivational interviewing. We are going to have a plan for the finalized version of that, the permanency plan by midsummer. So we should no later than early fall have this updated plan rolling out, have training on it, and we will all be experiencing eliminating some of the duplications where the information is being entered. It should reduce some of the work hours of our team members that they're spending writing these permanency plans, and it will help, most importantly, our families understand what is expected of them as they try and work through to meet success, get their children returned, and get their cases closed. So we will maintain getting feedback from our court partners, the legal representatives, our providers, who also need to be able to consume a lot of information that's in those permanency plans, continually giving us feedback, and we will continue to adjust as needed. The next update I wanted to talk about are efforts to standardize and expedite our family handoff from assessment workers over to the SWCM. So HHS and our FCS partners are scheduling warm handoff meetings within 5 days of the assessment being completed. The idea is getting those families while they're really motivated and eager to engage in those services. They are energized anytime the state CPW knocks on one's door. That tends to be a crisis. That is, for most families, a bad day. And sometimes that can help individuals move from pre-contemplation into contemplation around some of the work that maybe they need to do in order to make some changes in their life that would be positive and beneficial for their family. So some of these changes line up with what we saw in the CIA assessment, the idea that we need to be a service-ready system, and we really need to get those services in place as soon as a family is ready for them. The next area of work is also referenced in the CIA report, but it also syncs up with a national movement. And the goal here is to expedite licensing for relatives and fictive kin. There are a few critical issues taking place when they would be going through licensing. One of them is making sure that those safety, the safety needs are really being met, that the environment is safe for kids. We're going to be doing the background checks, the criminal checks, just like one would expect. But there is a lot of benefit to relatives and fictive kin getting licensed. They get financial support that's on par with foster parents. They get additional training. They get additional support in their home. And those are all good things. We do not want any artificial barriers, unnecessary barriers standing in the way between relatives and fictive kin being able to say yes to kids. I specifically want to call out that our sibling sets, far too frequently, there are economic barriers to an otherwise loving, caring relative or fictive kin saying yes. Yes, I can bring these kids to my home. The finances are real. And so anytime that we have an economic barrier and we can resolve that through some policy changes, some business process redesign, that is of utmost importance. And so I want to thank Matt Majeski. He was serving as the SBT sponsor of this work group. I am very eager to be briefed on our next steps forward, but I understand that there was clarity of vision and mission in this work group. And I have heard some in that work group even say, we may be able to get down to as short as 30 days. That would be amazing. I know that Michigan was first in the country rolling out these expedited licenses, and they are at 6 weeks. I do also want to make note that there are some administrative rules that may be standing in our way. Those can be resolved. We can work on those, and we will put those within our priority bucket to make sure that our rules comport with all of these federal expectations, align with statutes, but that we are getting to the best outcomes possible for the families that we serve. The last area of work we're going to be talking about is Thrive, and I'm going to hand this back over to Director Garcia to talk about that initiative.
Assuming I can make it to my unmute. So Thrive was mentioned in the governor's condition of the state, and I had many people right after that ask me, what kind of program is Thrive? It is, in my mind, not a program, but instead a shift in the way we do our work, shift in the way we approach the entirety of the way we meet Iowans' needs in health and human services. However, we have chosen to work closely with the families that come into child welfare in our initial launch of Thrive Iowa. And it'll be our goal to span in concentric circles across the entirety of who we serve so that Thrive becomes a true front door for needs. So at the core of Thrive is something that is incredibly important to us. Through our agency alignment and redesign and focused areas of work, as well as the culture build that we've been working diligently on to define the culture of the new agency. You know, arguably, it's a lot easier to move boxes and change programs than it is to change culture, so that part takes longer. But it was incredibly important to me that we have something that really speaks to the core of the work that we do. And in getting really close to a colleague of mine who used to serve as the secretary in Oklahoma, he introduced me to Hope-Centered Training, which comes out of the University of Oklahoma. There is a Center for the Evidence-Based Science of Hope, and I dove really, really deep into this body of research, its theories, and most importantly, its practice. And that is what we are deploying, both as the center of this work with Thrive, but really the center of our deeper culture work over the next several years. The really amazing thing about Hope is that we use it really in kind of ways that butcher its true meaning, right? We say, I hope you have a nice day. We actually can't hope you have a nice day because we can't change that, right? Hope is the ability to understand that tomorrow can be better and to understand that you, in fact, have the agency to get there. And the amazing thing about hope is that it can be taught. So if you lack the ability to see that tomorrow can get better, we can connect you with pathways to kind of unburden or unblock those barriers and build those pathways collectively. It's the core of what we do. And when I explained this to Janae, she was like, why do we need this training? This is what child welfare does. But it allows us to center around a practice model, again, a culture and a common language in our own agency, a vernacular that allows us to deeply understand why the work that we're talking to you about tonight is inextricably linked over to the Medicaid work. It's linked over to our work in state-operated specialty care, our facilities. It's linked over to aging and disability services in ways that historically our teams have had trouble kind of making those dots. And also to public health, which is fundamentally and first and foremost about understanding root causes and early intervention and primary prevention. So hope-centered training is being deployed across the entirety of our organization. Thrive ultimately takes that body of work and starts to shift positions to be navigators inside of our agency so that an Iowan understands a brightly lit front door to go into when they have a need. And the idea would be, when you think about child welfare, think about a family where we receive a high number of intakes. We go out to do an investigation or an assessment. Doesn't meet the statutory level of abuse or neglect, but it doesn't mean there aren't needs in the home. It functions in the child welfare space like a warm line. And what we are doing here is procuring an IT system, a closed loop referral system for the state, which is unique. We're actually the first in the nation to do it the way we're deploying it. Our federal partners are questioning exactly how we're going to do this. But the IT system, our ability in the state role is to be a convener and to have access to funding that community-based organizations, providers, faith-based organizations, and other partners that are key to the success of connecting Iowans with resources sometimes struggle to do. And in order to close the loop, you have to have everybody all on board. And so we intend to do that. We intend to buy the software and we intend to build that network so that the loop can actually be closed. And we can connect individuals to the resources they need. And more importantly than a concrete support, although that is incredibly important too for many of our families, we also can connect relationships in ways that allow us to strengthen families and communities long after we are out of their lives. And that aspect is something that we've been really diving deep into and learned a lot about. We are starting, as I mentioned, with kind of child welfare adjacent communities, really using our early childhood Iowa partners and thinking about the work that's already on the ground through both that body of work as well as public health work. We are launching in the central Iowa area and working with communities to decide exactly where. So I don't have that quite ready yet, but very, very soon. And then also launching in Southwest Iowa at the same time, likely in the Mills County area, because there's a significant amount of need there. And we expect to be starting late summer, early fall. And the IT portion of our work is, as I mentioned, up with our federal partners to gain that federal match so that we really do have a fulsome reach and sustainability in our deployment of the IT system. We are incredibly excited about the launch of this work. Okay. Last, but certainly not least, I think this is last. We are working very closely with providers right now, our QRTP providers, around safety and security. This has been in the works for a long time. I've been talking with them very closely. I see Christy on the call tonight. Christy and I have been talking about this for a long time. We've been thinking about some of the work we've done in our own operated facilities and how we've invested in enhancements which in our spaces look like different things, but a lot of cameras at the core of this work, in a way that allows, again, privacy to be secured, and they're not monitoring voices, but you're able to see with pristine clarity what occurs when a critical incident occurs in the facility. And it allows a practice and a culture to be born out of that really disciplined work that we think will be helpful. So we went to the governor's office and asked for some additional dollars above the rate we pay, because we know our providers need to invest in staff and training and a variety of other things. And we wanted to kind of lift this enhancement burden off of them. The governor eagerly responded with $1 million investment to really start this conversation. And so now we are working very closely with providers to think about what's right for their particular campus. Who do they serve? What does the physical space look like? There are different needs for different campus setups. And we do have a lot to offer, because we have gone through a variety of different deployments of security features in our own facilities. So really working closely with Dr. Hess and Ben Huntington, who are the architects of our remedial plan out of the training school, but work with other facilities as well for the unique needs of each of those locations. So wanted you to know about that. Again, wanted you to know it is a lot of work that is now finally coming to a rollout. And it's needed. So we will continue this conversation, as again, I mentioned in the beginning of the presentation, as we think about session and what conversations we're going to be elevating as priorities for the agency to work with the legislature on. Meeting the needs of supporting our providers to serve youth is at the forefront of that work. And I think there we go. So Claire is our communications specialist for this division. So if if you're and obviously we post these presentations. So if you ever have questions or you have agenda items, etc., you can always email Claire, because she will route questions to the right space. But I think for now, Claire, you can probably stop screen sharing and we'll take questions. Thoughts, comments, feedback, all of the above.
I have a few questions. Can I ask them both and get them out of the way?
Of course you can, Erin.
So first question is for the enhanced PMIX, when you're looking at the teams and who you're looking to bring in, what is the goal for that to actually look like in real time with the PMIX, and what is the goal in changing the culture there? I know that we're wanting to get rid of group care for what we know it as, but what is the goal with the PMIX? And then two, if you could give some examples on the court-ordered service funds of what would be acceptable that you guys would be looking at, and then examples of what is not acceptable and would be counterproductive, so we know right off the bat what will and will not be accepted.
Yeah. Well, and a piece of this too, Erin, I think in that latter question, not to jump the gun, because I actually will think that I'll ask Janae to maybe think about a few examples while I'm talking about the PMIC piece, but we'll need to have some session conversations, right? I mean, so what we say as things that we have questions around, the legislature may feel differently. Right. So, so we got a little work to do there, but let me talk about PMIC first. So, I mean, everyone knows PMICs are on a wait list in the state. We have a disproportionately high length of stay in Iowa as compared to other states. We worked several sessions ago to raise the rates for PMICs, and still not really coming down in those lengths of stay. And we have kids that we don't have a specialized provider for, and so we need to seek an out-of-state placement, and that is counter to our value structure here. So always striving to make sure that we're keeping youth connected with their communities and their caregivers and support network. So all of those things, Janae and Liz Matney, who's our Medicaid director, and I dug really deep on thinking about what do we want to build here specific to PMIC, and then kind of PMIC, and then we start to have a conversation around specializing QRTP as we know it, again, kind of talking about funding structures versus like what we want the physical space to look like, thinking about what shelter could be. Can there be shelter plus? What assessment tools do we have that we don't have in the system today, and how might we better utilize those spaces to provide that therapeutic intervention or assessment? And so I already happened to be with Janae and down in Florida for a child welfare convening. And so we asked Liz to come down and meet us to visit a provider we send a lot of Iowa kids to. We send a lot of Iowa kids there because they've never told us no. They told us no because they have a wait list, but they've never told us no. And we don't have a no reject contract. PMICs don't have that. So I wanted to see it. Like, what's the difference here? We've sent a lot of really complex individuals there who I can tell you, like, kids that have never gone to school that are going to school. And so, like, what is their secret sauce? Like, what are they doing there that we need to think about? And how do we support our providers? Because we know they want to. How do we support our providers, which is our goal and need to effectuate on that vision? And so Janae and I toured 3 campuses across the kind of central part of Florida, starting in Orlando and over to the Cape Canaveral side. They do, it's Devereaux is their name. They do a variety of different services. They operate in 13 states. We'll be their 14th if all things go according to plan. And they have everything from their things look different, and they have community-based care for child welfare. So there's a lot of things that I'm about to say that aren't apples to apples, but they serve youth with ID. They serve youth who are trafficked. They serve really complex youth. And they do it in a very transitional space. Some is shelter according to their rules, regs, and payment structure, but it doesn't look like our shelter. It's much more intensive, and it's locked. But it's not institutional, Erin. And so the thing that really struck me as we were on the tour, and Janae was there for most of it, Liz and I were there for the rest of it. Corey Turner came too. He runs our facilities. And what we were all struck by, like profoundly struck by, is that 20 or more people without prompting came up to us throughout the tour to tell us that they have worked there for 30, 35 years. Like, everybody there, how happy they are. And they're not paying any more than we're paying. And in the last space we asked, okay, once you've had enough critical incidents, when do you think about discharging a youth? And the room, not the leadership in the room, but the staff who were there, unprompted, like audibly gasped and said, we would absolutely never discharge a youth. So there's something happening there where they figured out a culture of that we're diving in deep with them specifically. And frankly, Erin, we've been doing and are still doing some of our own work in our own spaces. And I think I saw Corey's name on here. Corey's somewhere here. That has been a phenomenal learning lesson around the way you keep youth in a highly therapeutic environment, connected in shifts to people, right? Which is hard. Safe, for everybody involved. And that you really think about that intensive level of care. And Devereaux's been able to do that for a lot of youth for us. And so we are interested in that. And we also realize we need a rate structure that supports that work. And so that was the goal. We are interested in Devereaux coming to become an operator here. And so the legislature made a historic investment in a facility, like an appropriation that would go to a facility for them. So we are hopeful. They're working through the education process, which is never easy. But Director Snow has been very receptive to supporting providers on the educational pieces. And that's new for us, that we have a direct line to kind of triage some of those technical issues. So we would feel really hopeful. And the idea would be, right, that we have maybe initially, if Devereaux is thinking about 40 beds, they're thinking about 40 beds. We also, Erin, PMICs have to go through a certificate of need process, and there actually was a statutory cap in that's redundant, but in statute, around PMICs availability that for Medicaid specifically, and we lifted that cap during session. So we do not want to overbuild. Building our way out of this is not a thing, Erin. Like, I don't believe that. But we do have capacity issues and we need to specialize. And so what we're doing is really diving deep into, like, what are the very specific things we lack in the state? And we need a lot of feedback around that so that we get this build right. You know, if we need 40 kind of higher acuity beds, what under that 40 are the specialization areas? And PICA is something that I've had a lot of conversations on in the last, it's been on my radar for a long time. We serve individuals with PICA at our own facilities. It's challenging from a staffing perspective and a skill perspective. And we don't really have a service array outside of Woodward. And so what does that look like? Is it Woodward? Is it something else? What is that transition process look like? And Devereaux also has step down, more kind of independent living environments as well. Does that help, Erin? Yeah. Okay.
Thanks.
Yep.
Okay, I'm going to try and answer the court-ordered services. So I know you are a lawyer, so I'm going to draw your attention to a few things, Erin. There's the appropriations bill, which the language is pretty clear and was included in the PowerPoint. But there's also Iowa Code 232-141 covers court-ordered services, and then those sync up with Iowa Administrative Code Chapter 151. The language in Iowa Administrative Code, so the administrative rules, has not been modernized for a very long time. So what I'm going to tell you, if you were to read it, you would go, what does it mean in-home treatment services are not allowed to be paid for with COS versus in-home supervision can be covered? Some of that language is really archaic because our service array has adjusted over the past decades and those rules have not. So if you look in the administrative rules, they give examples of some of the items that are permissible to be funded, but I would not interpret 151 to be an exhaustive list. So it gives some examples. It says care or treatment to the child, salary or expenses of transportation, diagnostic services, drug testing, in-home supervision, evaluation of parents, etc. It does go on to say if the court orders a service not listed and it is not in conflict with another statute or rule, HHS can authorize payment. There are a few things that I would bring to your attention. One, judges have been at an extreme disadvantage of not understanding how much money is being spent statewide, even though it is one appropriation for all the judges. That is not okay. So one of the very first things we're going to do, as Director Garcia indicated, is we're putting together a dashboard. It's a Power BI dashboard, so it can be manipulated and filtered to get the information that an end user would want. They're going to be able to filter it expenditures by district, expenditure by judge, expenditure by what judges are ordering. Judges have very uneven patterns around the amount and what they are buying. I think based on some of the data I've seen, I think it's fairly breathtaking in terms of the differences. So that will be one area of interest, I believe. But two other things really stand out. How overexpended that appropriation is, and that language is pretty black and white, that actually the appropriations bill, no additional obligations outside of what has been spent in that approps can be spent. So we are really trying to work on this, and if those expenditures, if there needs to be more money, and that has not been adjusted for a long time, and legislators agree, I think that's good news for all. The third thing is we are becoming aware as we pay closer attention to these court-ordered services. It seems like there might be some Medicaid enrolled providers who are expected to take the Medicaid payment rate, but some may be aware that COS does not have that cap. So we want to be sure that would be a place where there is a regulation that is not being followed. So we want to pay better attention to that. If you're Medicaid enrolled and this person has Medicaid, you are expected to take that agreed upon rate. So again, just by paying better attention to it, we're going to be a better steward of those fiscal resources given to us by legislators. I can give you a random example of something that we may go, that does not really comply with the spirit of the administrative rules and law. We had a judge order us to buy a birthday cake. And while that is awesome, That might be one that people go, drug testing, evaluations, pastries, I don't know. But if we have that wrong, legislators can tell us.
Do you know when you're going to be rolling out the dashboard?
Yep, it's expected to roll out in July. So we will make a big to-do about it, and it will be up on our website, so super transparent. And I'm assuming that we will need to send out regular communication through the court improvement project to all the judges, just to draw their attention to it. They're very busy. We want to make this information available to them, like readily available.
No surprises here. Any other questions? I'm going to throw out my question that I started with because I'm just observing. I mean, I've asked a lot of our team to be present on these calls because I think it's important that they hear feedback, but we are most of the people on these calls. And so I'm curious, and maybe I'll aim this at maybe, I'm sorry, I'm going to call you out here, but you're right on my screen and you already talked, but Christy and Aaron, I mean, I just want to make sure we're hitting the mark in our communication distribution, our timing, like if we need to adjust to make it easier for people to attend, or if there is a different way that we should be approaching this so that we're getting more folks involved in the system who I think like our agendas are they feel pretty timely and like important items.
Yeah, go ahead, Aaron.
I don't know, people might be surprised. I don't have any negative feedback. I think it's going great. I appreciate the time that it's at. I think
you were just the sole holder of the information as legal counsel. We're thankful for your service.
5:30 is a good time. If it's any later, kiddos are getting put to bed,
right.
Things are getting in the way of that.
Right.
If it's any earlier, we're still doing, we're all working, but it's still doing work. And I like the 1 hour timelines. I like the information that's being provided. I do think it's pertinent to what is going on in our daily work. And so I appreciate these a lot. I'm really glad that you guys are hosting these. And it makes us, I think, feel comfortable asking those questions, feeling that this is an open kind of conversation, which I appreciate. So I appreciate this and the time. I think it's working out well.
Okay, good. Well, tell your friends and colleagues.
I do.
Okay.
And then I type up all the notes and send it to them.
I'm going to see Director Wright and I'm going to tell him about it so that he can spread the good word here to parents, attorneys, children's attorneys, and guardians ad litem. What do you think, Christy?
Yeah, I think it's going well. I mean, I like the format. I think one of the things, because one of my questions is kind of around Thrive, and a lot of our FCS contractors got trained as Hope champions. Like, how do we connect what you guys are doing to kind of the provider side to make sure that we're going alongside you and not kind of doing our own thing with the Hope research? I think there's a lot of good things going on. And I think if we can tie what's happening with contractors to the big system thinking, sometimes it's hard to get out of the weeds when there's a lot of changes in contracts this time of year.
Yeah. Well, and speaking of, like, we are thinking about how to center some of this Hope work in contracts. So, so that it is measurable and an expectation, and that'll roll out. We don't want to overburden an already overburdened system, but we, and I mean that large scale to HHS, but, and we want to be thoughtful when we're asking for metrics. But we are thinking about that, Christy. I think we probably just schedule a conversation because we have a project manager around this work. Dr. Horak is leading it in Janae's division for the rollout, but there's absolutely an intention to ensure that all of our providers are centered around that work, not just in the training, but in the execution.
I think one of the things that I realized today, we had a QRTP meeting. I've been doing this for a while, and the idea that there's only 6 contracted QRTPs now, it's just trying to, what's our expectation of how many people do we expect to have in these conversations when there's actually less and less providers doing the work? And I'm sure it's the same on the attorney side. I know too, there's less and less attorneys doing this work.
Yep. I mean, I think, Christy, to your point, and we'll let you in on the conversations Christy and I have been having for quite some time, but is to then work with providers to keep their work, again, like much what I think about our own work in our facilities, like evolving with the needs into a space that is a business arrangement that makes it a bit more palatable. Those enhanced Medicaid rates get us to that space, I think. And that is the space that is able to meet the needs with the right level of clinical capacity and training that I think we're seeing evolve nationwide. And then just remember that for confined juvenile justice settings, we will have a Medicaid requirement to cover services for youth very soon. So that's also another component when we think about transitions in and out of confined settings into more therapeutic settings. This payment structure allows us to bring those services in to confinement in a way that is not typically being executed on by the region. And it'll become a Medicaid eligible. So you'll see continuity in different ways across the portfolio of kind of brick and mortar spaces. Although the goal would be to not rely on those levels of care, but. Anyone else? We've got about 2 minutes left. Any other thoughts, or Erin and Christy, any agenda items you'd like to see next time?
FCS, I texted Janae actually. I would love to see some dedicated time to the
Okay.
FCS because it's a struggle across the state and the contract and expectations. And when you have family members or parents who are separated and we're separating one visit a week and we don't have safe family members and we're trying, I would love to see some time on the thought behind the contract, where we're at, what can we do? Will things change in the future? Will they not? Just that.
Fair. That's good.
I don't know if this is ripe for conversation yet, but just something to put on our radar is kind of like the future of the DCAT funding I know the alignment that the state is working on that. And so how do we kind of stay informed on the forefront of that work too?
Yep. I mean, I think from our perspective, it's not dissimilar to the conversation we just had around court-ordered services and the way Janae kind of opened with the answer to Erin is that so much of that language is kind of archaic for us. Our service array, we have statewide services and a build in a variety of other ways. So there could be items that we're paying through that mechanism that might still be valuable, but it's a machine of work for something that we don't utilize in the same way. But we're not the only people who utilize that system. And so then we have to, I feel like, have a different conversation with the legislature around this kind of entangled space with JCS. And how do we, I have no desire to leave them strapped for resources in terms of being able to navigate that. I want youth to be served, but at the same time, we don't feel the same compelling need to have a structure like DCAT any longer. And so we intend to kind of wean ourselves off of that and think about doing work in different ways. And that holds true for a variety of different funding streams that flow through our organization. Because we've got a different perspective. We have all these programs together and we're able to kind of line item things into a financial arrangement that is, I think, clearer, better utilization of federal funds, and with better oversight of what we're purchasing and the metrics around it. I mean, we're buying a lot of things in a lot of spaces in HHS historically with little to no measurement around whether that item, that thing, is doing what we hoped it would. Okay, we're right at time. We've got agenda items for the next couple of town halls. So thank you, Christy and Erin. Okay, no last folks. I hope you all have a great evening. Thanks so much for taking the time to join us.